So this is just real informal, no pressure. So I had a couple questions, and that I just wanted to ask, and this is really just to kind of help give you guys an idea of just to put a face to diabetes and what it means to be a diabetic and what they face on a daily basis. So I think I'll start with you, Paul. Just try to go in order. I've worked with Paul a long time on his diabetes. We've been together a while. Does it work, Paul?
Testing.
Got it. So, Paul, what has been the most difficult aspect of living with diabetes, whether that's emotional, financial, or related to your daily routine? And I know we've talked beforehand, and I've said before, I think it's financial, but I want you to hit on that and kind of give them an idea of what you have to go through with your diabetes care.
Well, first of all, I'd like to thank you for everything you do for the diabetes in this area. And for me, on the day-to-day basis, and speaking on the financial part, is it's hard to understand why that our insurance companies can't provide us with the medicine that we need. And it's just like living day to day on a fixed income, that you can't afford this medicine, knowing that there's medicine out there that can maybe help you, but you can't afford it. The insurance people say they can't afford it or whatever. It's hard to understand that, why there is so many people that you speak with that has diabetes. It's amazing to me when I talk to the public that how many people are afflicted by this disease. And sometimes it's hard to think of it as a disease, but it affects your body in so many ways. The loss of strength, to just feel like you just don't have the energy to do what you need to do on a daily basis. And sometimes going myself without medicine that I need. And that would be my biggest thought on what I have to suffer with day to day. And believe me, if you're not a diabetic, you can't understand this, because until I realized and was diagnosed with what it was, I never understood what my body was going through. And just and then when they said that, oh, you got sugar, we call it sugar a lot in the mountains. It's called, we don't call it being a diabetic, so you have sugar. And I think, well, that's not too bad. I just got sugar, But when I began to understand it, it's such a terrible thing. But I thank all of you for coming out and showing support for us. Surely, I would like to see things happen that we could be able to get the medicine that we need. It's not only for myself, but it's just like I say, so many of the people that I talk to, I couldn't believe that are diabetics until I just started mentioning it to people. But I'm glad to be here today, and hopefully something that somebody on this panel would say could enlighten somebody to do something to help the people in Eastern Kentucky, and not just Eastern Kentucky, but all over the United States. Thank you very much.
And Dr. Raj, I'll kind of push and follow up with that just from our perspective. I know how I feel about it sometimes, but there's a lot of new medications on the market, a lot of medications that they come in and they say, hey, they've got all these great benefits, can prevent dialysis, can prevent heart attack and stroke. And can you speak to that, Dr. Raj, on maybe how disheartening that can be when you struggle to get those medications to your patients?
Yeah, so thank you for organizing this event. This is my first event in this area, and I think there is a lot of things to take home from here. Talking about new medications, so I was just reading, I kind of check news all the time, and there was an article there where they said that Novo Nordisk, which makes Ozempic, made 8.9 billion in profit in last 3 months. And the company which makes Mounjaro, which is the next big medication, made 9.5 billion in last quarter. So I don't know why they can't give it to people who have some kind of insurance, why they have to deny it. I am from a different country. I studied in India, then came here, and then trained here. So I have a perception of both the countries. Insurance system is not like this in India. I mean, if there is any medication available, it has a maximum retail price, and anybody can buy it for that. And that price is subsidized by the government, which makes it affordable. So these medications are much more affordable in India. The price of the same medications are expensive in US. I don't understand why. Some insurance company covers it, some insurance company doesn't cover it. These things are beyond understanding. The guidelines comes from American Diabetes Association, and it has its own recommendation on what medication to be given first, then next, then next. There is very clear-cut guidelines. I do not understand why the company cannot just follow that guideline and rather make its own guidelines. So it's an unfortunate situation, and I do not have an easy fix for that. But definitely, I work with a lot of patients who are in similar positions as him. There are some programs which help patients who have who cannot afford these medication, and there is some patient assistance program, and it is not difficult to get enrolled for those programs, and somehow these medication becomes free for whole year, and then you can renew it for next year. So in the interim, that's the solution I am providing to my patients who cannot afford good medications. But most of my patients are meeting those criteria to get the patient assistance, and they're getting it for free. So that's one solution in the interim.
So Morgan, I'll give you some context with Morgan here. She is a dietitian. She works at ARH Hospital. And honestly, Morgan, I'm not sure what question we're going to do, but I know you know what we're going to do. So I want you to just spill what you have to say to us about your experience with diabetes and maybe what it is on a day-to-day basis, what it means to you.
So day-to-day, I mean, you have to think about every single aspect of your whole day. You know, what time you're getting up, how soon after you get up you eat, if you have to time it with medications. Like I'm on Synthroid, so I have to wait half an hour before I can eat. You know, you have to be prepared for anything. I packed 5 juice boxes today in case I got low. But it's a lot of stress that I don't think people realize. You have to plan, you know, every step of your day. If your schedule changes at all, you know, that can lower your blood sugar. Normally I eat at 11. Today we didn't eat till 12:15. So then there's the chance I get low in there. It's really just every aspect. If you're going to exercise, you know, timing that with your insulin, and when you work full time, you know, have a family, it's just really hard to balance everything. And then, you know, doctors are like, or, you know, just people in general wonder why you can't control your blood sugar or comply when it's, you know, you're trying to work full time, and then managing diabetes is a full-time job too. So it's just really difficult to balance all that.
Maybe a baby makes that harder.
Yeah,
too,
baby
as
makes
well.
that
Baby
harder.
makes that harder. Children
Yeah.
make that harder.
Yeah.
Okay. Melissa, I'll shoot this one to you. What are some common misconceptions about diabetes that you've encountered, and how do you handle those?
Okay, I've kind of been around diabetes all my life. My father had it, but that was back, and my mom had a lot of misconceptions when I was diagnosed. She wanted to treat me like they treated my dad. And, you know, there's been a lot of advancements since then. And my biggest misconception was food. I thought I had to not eat so much carbs, not eat. I was trying to do it myself after I got diagnosed. And then Ashley came into the picture in ARH, and I had my first meeting with her. She said, you can have 45 grams of carbs per meal. And I was shocked. I wasn't eating close to that. And I couldn't understand why my A1C numbers weren't going where I wanted them to be. Well, I wasn't eating enough. I wasn't eating what I should have ate. I just was trying to do it myself. I've been going to the support groups, and that has helped so much. We get those meals cooked for us and get to taste of the good, healthy food, which I am not a fan of, but I'm learning to become. I'll just be honest. I was a teacher, so I learned to eat really quick at lunch. You get 20 minutes, but you got to have time to go to the restroom, do whatever, and then be there on time to pick up your kids. So I was a fast eater. That's another thing I'm learning in retirement. I can sit down, I can enjoy my food. I don't have to rush and eat. And activity. I was active. I mean, every now and then I would, what you would call workout, but I thought I was active enough when I was working. Come to find out, go for a walk. 30 minutes a day is all I really needed to do. I didn't need to kill myself. And we will know next week. I get my next A1C since I've started seeing Ashley, and I know it's going to be better. To the insurance, I'm blessed. I'm a retired teacher. I have decent insurance. But they would not allow me to have a continuous glucose monitor.
You've got one of those on.
Yes, I have a story. Because I do not take insulin. I'm on pills right now. I'm starting that. And a year or two back, I got on Dexcom, and I worked it out, and I was allowed to have a Dexcom 6, and it went fine for a year. Well, my insurance changed and said, oh, you're not on insulin, so you can't have it anymore. And I had to go back to the finger pokes, and I don't like those. And I did not do them like I should. So I did not keep up with what my glucose was. And I went back on there, and I saw that they said, oh, we've been working with some insurances. So all last week, every day, I called my insurance to get. And I finally got my pre-approval. And I was able to pick up my Dexcom last night, and the first thing I did, I sent Ashley a picture. I said, look what I got, because I know it's going to make my life a whole lot easier and help me control it better. But the misconceptions of just, oh, you don't need to eat sweets, you'll be fine, and, lower your carbs. You got to eat, and that's what I learned. I have to be able to eat, and I know what I can eat now. So,
Dr. Raj, do you have anything to say about maybe myths or misconceptions that patients come to you with about diabetes?
It's not a misconception, but oftentimes we tend to forget the most important thing for people with diabetes. I tend to say people with diabetes, or at least I try to say people with diabetes rather than patients with diabetes. It's just more human. Quality of life. Of all the things, we tend to forget quality of life. Hemoglobin A1C is a number. If it's 6.5, it's great. If it's 6.0, it's great. But if you are happy at 6.7, that's much better than anything other than having a better number. So what you can do to have a decent quality of life without being stressed all the time and having a good control of your diabetes as well. That is what I want. And I talk to my patients. Sometimes I turn into a preacher while talking. So I think I make a relationship with my patient and just bring them to where they are happy in their life. It's not always about number. We don't always want to live to 100 years. It's all about how we can be happy and die without any major problems and have a good control of our diabetes. Yeah.
So I'll open this up to my three diabetics here, and you may not have an experience, but I want to ask the question. So could you share an experience where maybe you had a diabetic emergency or a critical situation, and can you kind of expand on how did you handle that, and did it teach you anything about managing your condition? And that may help us understand kind of the cost and what happens when you have some kind of emergency, whether it's a critical low or critical high. Does anybody have any experience with this?
So this was shortly after I was diagnosed. So I was diagnosed when I was 12, and I was sick. So I was throwing up, and we checked for ketones, which were positive. I was dehydrated. My parents took me into the emergency room, and the emergency room physician said since my blood sugar wasn't, like critically high, I was fine, and sent me home when I was probably in DKA. And so even it taught me you have to fight for yourself. I was young. I didn't understand. I was newly diagnosed. So my parents, they weren't as confident in their knowledge either. So even, like with medical professionals, you need to, and if you feel like you're sick, if you're not doing well, you need to stand up for yourself in those situations. Not everyone is an expert on diabetes. I mean, as an emergency room physician, they should have, checked me for ketones, which they did not do. So, that was kind of a lesson there when I was younger that any critical situation, whether it's a high or low, make sure you get the help you need because I didn't get it that day.
Paul, you have something?
Well, I can relate to what she's talking about a little bit. I remember when I first got diagnosed with this, I guess I have always depended on myself. I really never had a lot of confidence. I just have to say it in doctors and medicine. I had to come to learn to trust them. But I was trying to get a little exercise, as she was saying. Instead of using a riding lawnmower, I was pushing the lawnmower. And I got to the point, I was home by myself, and I almost panicked because I felt like I was going to pass out. I just got so weak, and my vision was blurring, and it was really a scary moment. Actually, I didn't go to the doctor. I just, like I say, I'm one of the ones that thinks, you're going to be okay. I probably should have had someone take me to the doctor, but I got inside, sat down for a while. But that was a very scary moment for me, and I'd had that happen a few times. But that, I guess, is when I really began to see how real this is and how dangerous it is with the risks of heart attacks and strokes. I mean, it's a very scary thought when you think about it, and it's something that needs to be taken seriously if you have this problem like I do.
Melissa, did you have anything? Okay. So I think I've got one more question, and then if we have time, if somebody else has something burning in their mind, that feel free. I'll bring the microphone to you, and we'll ask the question. Something I'm going to open it up to everybody again. Is there any way that diabetes has impacted your relationships with your family or your friends? Like maybe an example where they seem to not understand you, or that you needed their support?
The biggest problem I have with family is coming up here within the next 2 months. All the dinners that you go to, and they'll say, well, you can have a little bit, it won't hurt you. And, they say, we made this especially for you. And it's hard to say no. And that kind of causes a little
Yes.
conflict with the families.
It's a cultural issue, right? Mama and them are insulted if you don't take part in the in the feast.
I want to add one thing, like we are going into the season, the holiday season, and I expect all my patients' diabetes control to worsen when they come and see me in January, February. And I'm perfectly okay with that. A little bit of uncontrol is okay. It's not end of the world. It's okay to enjoy life a little bit. What I tell each of my patients is just to watch the portion going into dinners during the holidays. That's about it. I think it's okay to try and taste everything as much as you are watching the portion. Now, most of my patients are on insulin, and they most likely are also on continuous glucose monitors, and they are a great tool to see if you are doing too much. You will know when sugar goes very high, and you will yourself, without anybody telling you, you will adapt, you will change your behavior. So I don't think much needs to be changed. It's okay to enjoy a little time.
I've been pretty fortunate with like my close family, my husband, that they've all took time to educate themselves and listen to what I have to say about diabetes. So I'd say my relationships is more so with kind of like more distant family. Like, I don't know why my husband's family always wants to eat at like 2 p.m. and I like to eat at like 11. So like, family dinners, they'll like, sometimes my husband will be like, well, could we do, if they're discussing times, can we do it a little bit earlier for Morgan? Like, why can't she just eat a snack? It's not the same as eating a meal and, rearranging, where you have to rearrange your whole schedule. So close family's been pretty good. The distant family, not so much, or, they don't understand the difference between type 1 and type 2 because, the majority of people do have type 2. So I have to do a little education sometimes on the difference and why I can't, do something a certain way.
Right. The good news is you can educate them on that because you're a dietitian. So I mean, that makes a good point. I think it's something that I've not really thought about, but it's more than just about educating the patient. A lot of times you have to educate the people in their sphere of influence that are going to impact the decisions that you make every day, like Paul's mama here, or her wife, or whoever's pushing the food on him. Yeah, I'm sure they twisted real hard, Paul. I'm sure they twisted hard. So, and then I'll say something to Dr. Raj's point because I said this earlier, and I don't know if he took that from me, but yeah, pretty much in January and February, when I check those A1Cs, I kind of just go, I just kind of, this is what's going to happen, because you can have somebody who's very well controlled. It could be sick, their A1C is sick, their blood sugar's perfect, and then I'll see in January and February, it's went up a point or two. And I don't necessarily go after that and make changes to their medications. And like clockwork, the next time when I get it in April, May, June, it's better. And so sometimes I think physicians take the risk if they're just looking at the numbers and not considering the whole person, and the fact that Halloween and Thanksgiving and Christmas all happened in rapid succession, that we may up their insulin or change their medications. And then the next thing you know, you're having hypoglycemic events, low blood sugars, and you're actually causing that patient some problems because they cheated a little bit in the holiday season. So that's something I try to look at every year, and I just say hold my nose and just ignore it if it's not too bad. Okay. Does anybody have any questions for anybody on the panel? Just raise your hand. It's okay if you do or don't. All right. Go ahead, and I'll let you ask it.
Across our country, there's 30 medical systems that have banned the sales of sugar-sweetened beverages. The National Health Service hospitals of England have banned the sales of sugar-sweetened beverages. There are scientific papers that support there's a direct proportional amount of diabetes to the amount of sugar-sweetened beverages that are consumed. Do you think your local hospitals may take up the bandwagon here, or take up the position with some of the major medical centers like the Cleveland Clinic, Dayton Children's Hospital, University of Michigan, Baylor University in Texas, even Jefferson Hospital in Ransom, West Virginia, a 25-bed minimal access hospital? Should we have other medical centers join us?
Working at a hospital, there would be some uproar. I know people want their caffeine and they want their sugar when they're working. And I mean, they can always bring it from home, so there still would be that access. So I think it kind of goes back to the education on, I mean, as a dietitian, I see every day the misconceptions about nutrition, or, people just don't understand the importance of like the food as medicine. So, I mean, it would help with the consumption some probably at the hospital, but it goes back to that education and starting to from, like a younger age. I mean, I've been to the park and seen 3-year-olds with Mountain Dew, so starting at a young age in families, decreasing the sugar consumption and, the healthy intake, or, healthy meals, and increasing fruit and vegetable intake and exercise. So, I mean, I don't know long term if, banning that at hospitals would have an impact or not, but I really think it goes back to kind of the education aspect of it.
I don't think we can enforce this in the community here we live. It has to be driven from the community that they want to reduce their sugar intake. I had patient other day and A1C is like more than 14. That is the maximum our lab can check. So more than 14 might mean 18 or 18, 19 of A1C. Sugar is into 400, 500s. And I'm talking, are you eating like junk food or things like that? And I'm talking about, are you drinking soda, Coke, Pepsi? And no, no, no. Answer was always no. And then I'm like, okay, tell me what you are doing whole day. And then I'm listening to drinking lemonade. So that, so like, unless I go into detail, I will never know what they are doing, and they don't realize lemonade is sweet and it has sugar. It is maybe equally dangerous for a diabetes patient for like who drinks soda, regular soda. So yeah, it has to like literacy has to start like at community level, and then it can be enforced later. Yeah.
I'd just like to say on that, sir, that there's so many misconceptions about drinks. Do we stop drinking milk? Do we stop drinking, like he said, lemonade? You can't really impose this on people. I have to agree with their dietitian here that people have to be educated and find out the true things about these drinks. On one hand, we hear, hey, it's better for you to drink a regular cola than it is a Diet Cola. And then they say, well, it's better to drink a Diet Cola than drink a regular cola. There's so many misconceptions about these things that myself, I don't understand, because you don't know who to believe. You know, it comes back to educating people, I think, before you start saying, hey, don't do this, because you tell someone around here he can't do it, he's probably going to do it. That's just the way we are.
And the companies here and the like stores here, they sell all these things up front. Like it's very hard to find something nutritious and easy to find something which is not like good for health. I mean, recently I'm like trying to find something which is sweet and rich in protein. So I ordered something from Walmart online, and I found a snack. And I ordered it and I got it. It's a cookie, and it's a protein-rich cookie because I ordered that. And I'm seeing 1 gram of protein and 6 gram of carbohydrate. And you have to eat like 6 of those cookies to get 6 gram. And you will eat like how much? 36 gram of carbohydrate in that. So how it is protein rich? Even I did a mistake in ordering that. So it's hard. It's very hard to choose good food options here. There are not many. Yeah. And I think education, diabetes education will go a long way, because diabetes is not about managing it for today or tomorrow or like in 1 year. It's lifelong. So it needs like education at grassroots levels.
I think that was a great question. It's a loaded question that can be controversial in many ways, because now we're talking about liberty and then we're talking about trying to help with diabetes. So I think that's a great question, and I'm going to join the panel for a second. So I think to your point, and then I see where some of the mindset is people have to choose and you can educate them. But I'm not against freedom, but I do believe that those things are probably effective. I don't know if they've done studies necessarily to show how that impacted those health populations in the hospital, but I would bet it would be positive. So it's a human psychology thing, and if you've read any books on habits, Atomic Habits is one, it's just as simple as changing the environment to change people's behavior. So yes, they need education, but I guess I can get extreme here. If you have a patient who is addicted to drugs and the drugs are on the table and I educate them why they shouldn't do it, it does not make them not do it. So those measures I would say are probably effective. It's going to take education, but it takes an environmental change to build habits. If you want somebody to work out every day, if you've got your clothes laid out to work out before you get up and it's there and you made it easy, you're more likely to do it. If there's water instead of a sugary drink, lemonade, what choice do they have but to choose it, and then they build the habit. So as somebody who's studied a lot of psychology and building habits, I think that's where they're going with that, and I think that probably is very helpful to change the environment. And even though, yes, it's a free country, it's their hospital, and they can run it how they want. They can make it smoke-free. They can make it sugar-free. So I see to that point. And so you have put some pressure on some people today, my friend. I think we're close to closing. Any other questions? We have one from...
One thing, as a practitioner, you have to take, I had the opportunity to take patients shopping and make them look at the
labels.
ingredients. Then the other thing that I was so surprised is chewing tobacco, that I never realized how much sugar was in chewing tobacco. I guess it would be hard just to chew a tobacco leaf, but I had my patients open up that little pouch, put their hand in there, and feel how sticky it was. Because that doesn't have any content of sugar on the package.
Right. Yeah, I agree. Looking at packages and learning total sugars, carbohydrates, sugar-free. I tell patients is a trick all the time that they use sometimes on our diabetics. They say it's sugar-free, but it is loaded with carbs. They're just not pure sugars. So that's a good point. Any other questions, comments? Oh, I have one back here. You're going to make me run to you? I'm doing it. I'm coming, Nicole. We'll do it.
So my question is, see, I told you I have a big mouth. My question is, do any of you, I do community work, and so do any of you all feel like that there is something that is needed in your community? I know we have your all's awesome center here at Primary Care. There is a new support group in Hazard that has started. We have Ashley, who is an educator, but is there anything else from a community standpoint that healthcare organizations could do or offer to you all?
I think there's a lot more resources than there used to be. Like when they posted Ashley's position, and then she took that, and I've been in communication with her some about what services she offers. I was really excited about that. And like we have a dietitian at UK and Hazard. So I think there's a lot more resources than there used to be. I do think, which Ashley talked about this, the food insecurity, and trying to get more resources for that. If you don't know where your next meal is coming from and you have to choose between that and your medication, paying your utility bills, I think that is a really big barrier, and then trying to do more education, which, I think there's a lot of programs trying to do that. And I do feel like in the last few years, I've lived in Hazard 8 years now, and there's a lot more resources than there used to be.
It would be hard to say what could be done within the community, but we keep getting back to the dietitian on this, because I think she's made a lot of good points here. But it seems like the day that we live in, there's not the family meal like it used to be. We don't sit down at home, everybody at one time, and eat, and half the time nobody eats the same thing because of the different work schedules or whatever, or school schedules or things. And it really seems like, I guess we get back to I think of the cost. The cost of the things that we really need to eat are so much more expensive. If you look at like a salad at McDonald's is so much higher than like just getting a burger. A lot of times it comes back to the cost and the affordability of eating these different foods that's really good for you.
Okay. Any more questions?
I want to say just one thing, just about what the communities can do. I'll be honest, I did not even know there was a diabetic center up here until today.
It's getting the word out, isn't it?
And yes, that's the word needs to be out that we have all these resources between primary care, ARH, Pikeville, all the different resources that just needs to be out there. And that would benefit so many people just knowing, hey, well, my local doctor has a diabetic nutritionist there that I can go talk to. Or there's a diabetic center I can go and get my feet checked or my A1C checked. Yeah, I was shocked. I saw the agenda and I'm like, I didn't know this was here, and I've lived in Hazard all my life. So that's the main thing, is getting the word out about all the resources we do have right now.